Ever thought of the liver as your body's chemical plant, not just a detox organ? Today, we're diving into how it runs the whole show, especially for your board exams.
That's what's wild. Most people imagine the liver as a filter, but for clinicians, it's basically the central dispatcher for energy, proteins, and, well, basically every metabolic process you can name.
Absolutely. In this episode, we'll link the liver's day-to-day hustle to big pathologies. Think fatty liver, coagulopathy, jaundice, and hepatic encephalopathy.
We'll start with how the liver juggles glucose and lipids, then cover protein synthesis and clotting, break down bilirubin pathways, tackle ammonia and encephalopathy, and wrap with killer exam clues from portal hypertension. Ready? Let's get metabolic.
What always trips students up is how the liver flips the metabolic switch between feeding and fasting. During fasting, it's not just breaking down glycogen, it's also making new glucose with gluconeogenesis.
Exactly. And don't miss the lipid side. The liver doesn't just store fat. It packages and ships it as VLDL using ApoB100. If that export process stalls, say, with malnutrition or toxins, you get fatty liver or hepatic steatosis.
It's a subtle distinction, right? If the liver can't export VLDL, fat piles up inside the hepatocytes. That's why steatosis isn't just about excess intake, but failed secretion.
And on boards, if they mention a patient with impaired VLDL export, always think about what's blocking the shipyard. Are we missing the cargo, ApoB100, or is the machinery poisoned?
Let's shift to the liver's protein factory. We all remember albumin, but that's a slow change marker. If you need to know the liver's status today, PT-INR is your best friend.
That's crucial because factor VII has such a short half-life. PT rises fast in acute liver failure. Plus, thrombopoietin often gets overlooked. With cirrhosis, low platelets aren't just splenic sequestration, the liver stopped signaling for new ones.
I've seen students focus only on the spleen when platelets drop. But if thrombopoietin is missing, the bone marrow just won't keep up. It's a dual hit.
And don't forget, coagulation factors 2, 7, I, and X, plus proteins C and S, are all liver-made. So when PT is up, think about which factors dropped first and why.
Let's untangle bilirubin. High-yield territory here. Can you separate unconjugated from conjugated lipid versus water-soluble?
Unconjugated's the troublemaker. It's lipid-soluble, can sneak into the brain, and causes kernicterus in neonates when it spikes, like in hemolysis or rare enzyme defect.
Exactly. But when conjugated bilirubin builds up, patients get dark urine. That means the liver did its job, but something downstream like a stone or tumor is blocking the exit.
And here's a board favorite. If the gallbladder's empty but conjugated bilirubin is high, think Dubin-Johnson syndrome. That black liver on biopsy is basically pathognomonic.
Switching gears, let's talk detox. When the liver fails, ammonia builds up and the brain pays the price. Astrocytes try to save the day by turning ammonia into glutamine, but that just leads to swelling and confusion.
And that's the real core of hepatic encephalopathy. What's wild is how lactulose works. It acidifies the gut, trapping ammonia as ammonium, which can't get absorbed. We're literally engineering the colon's chemistry to save the brain.
Students often think lactulose is just a laxative, but the real magic is the chemical trap for ammonia. That's such a clever therapeutic move.
And clinically, always check ammonia levels if you see altered mental status in liver failure. Don't miss that step. It's central to acute management.
So, chronic cirrhosis transforms the liver, fibrosis boosts resistance, and the whole portal system backs up. That's when you spot those classic physical signs.
Esophageal varices are brutal, they form, because blood can't get through the liver and finds detours up the esophagus. And caput medusae, that's the umbilical vein reopening, which is wild if you picture it.
Hyperestrogenism is another board classic. The liver can't clear estrogen, so you start seeing spider angiomata and gynecomastia. These subtle findings are huge diagnostic clues.
If you see a combination of those findings, always consider the stage of cirrhosis and how compromised the metabolic clearance really is. It's all about connecting the pathophysiology back to the bedside.
Let's close with 3 high-yield takeaways. First, a high PT means the liver's synthetic power is down. Second, direct conjugated bilirubin spikes point to a blocked secretion path. Look for obstructions. Third, a rising ammonia level signals failed detox.
And here's your next clinical move. When you see signs of liver dysfunction, always check PT, bilirubin fractions and ammonia together. That trio tells you where the liver is faltering synthesis, secretion, or scavenging.
Brilliant. For anyone prepping for boards or rounds, keep those 3 S's in mind every time you approach a liver case. It's a quick mental framework that saves you time and points.
Thanks for tuning in. Hope this made the hepatobiliary maze a little clearer. Go test yourself, quiz a friend, and don't forget, when in doubt, think like a hepatocyte.